This is The Voice of Aging, hosted by Brynne Malone, owner of Aging Solutions. Real talk, expert advice, and trusted resources to help you navigate aging with confidence, clarity, and peace of mind. Hello, and welcome to another edition of The Voice of Aging. I'm your host, Brynne Malone, owner of Aging Solutions. Today, I am happy to welcome someone from the fire service. They spent most of their life in the fire service. We'll dive into that in just a minute. But this is Fire Commissioner Greg Anderson from Spokane County Fire District 9. As you all know, if you've been watching the podcast over the last many months, you know that we're located in the Pacific Northwest. But the information that we hopefully you get today and learn today is applicable no matter where you are in the United States. But as we always say here, check with your local county or fire service if you have any questions about any topics that might come up today. But Greg, we're just so happy that you are able to join us today and shed some light with our audience about fire service, some of the challenges that you run into in the fire service, particularly around the medical responses or medical calls that you go on. So we'll dive into that. But before we get there, we always like to let our audience know a little bit about our guests. So can you tell us at what age or about how long you've been in the fire service and how that started for you?
Well, basically, you might say I've been in there all my life. My father started as a volunteer in 1966.
Okay.
And I would say I was 6 years old at that time. But through those years, my dad was a volunteer, and he eventually became a fire commissioner. But I joined the Fire District 9 as a volunteer in 1980. And then I was hired as a full-time career firefighter in 1988.
Okay.
From there, I worked my way up through the ranks. I became a lieutenant, captain, division chief. Then when I retired in 2023, I was assistant chief of operations.
Okay.
So I retired at midnight on December 31st, 2023. And that fall, I'd been elected as a fire commissioner to serve a 6-year term. And so on January 1 of 2024, I became a fire commissioner. So technically, this is my 45th year or 46th year in the fire service.
Okay. So this is obviously a passion for you.
It was. It's been really kind of a dream job for me. I never felt like I ever went to work. I always look forward to get up and go.
So the fire service, obviously, when we think of a firefighter, we think that you're on fire calls all the time, day in and day out. What's the reality of that? How many fire calls do you go on?
I mean, our call volume has drastically changed over the years as our demographics have changed and our people. But basically, about 80% of calls are in the EMS assist type of world. Another 20% are dealing with fires, alarm systems, car wrecks, and things like that.
Okay. So 80% are EMS or medical calls.
Of some type, yeah.
Okay. And then you mentioned fire. You kind of bunch the 20% in with fire calls and auto accidents and, what rescue calls from climbers or boating accidents, that kind of stuff.
Yeah, I mean the way we do our national reporting in our every call you go on that gets an alarm number, you do a report.
Okay.
And the coding and stuff like that's changed over the years. So in theory, it looks like there's less aid calls based off of what, something happened, somebody fell or needs assistance up.
Yeah.
That's used to be, we just kind of lump that in. I generalize that, the fire part where you think of firefighters fighting fire and put your turnouts on really only relates to about 20% of the calls. The other 80% really are some type of assistance call, whether that be aid calls or whatever.
Okay.
I mean, as always, when we look at our monthly end of the month fire reports, it looks like our aid calls have dropped slightly, but that's based off of the way things are coded.
Okay.
So.
It really hasn't changed the call itself. It's just the coding of the process. So I think today for our audience, we're going to focus on the medical piece of that. I mean, I know that the firefighting is kind of glorious and you got the flames and the smoke and all that's kind of fun, but As a child, and maybe you watched this show too, Emergency?
Yeah.
Yeah. Okay. So that was all around paramedics, right? And how they communicated with the hospital system. So being that my memory is a little rusty, I had to write some things down. So I'm going to look at so Emergency aired from 1972 to 1977, and some of the characters were paramedics John Gage and paramedics Roy DeSoto. Okay. Always my heroes. And they communicated with the ER doctors Brackett and Morton and Nurse Dixie McCall. And that's the first time I ever heard of lactated ringers. Like, what is a lactated ringer? I never knew what that was, but I felt like a professional because I know, Emergency had lactated ringers. So is that a reality or is that just television?
Well, I mean, we use like a sodium bicarbonate type of, I know that's the right term. I'm not a paramedic. I was an EMT all those years, and I work with paramedics. But an IV is just a solution for,
Hydration, stabilization,
and being able to run medications and different things like that, blood loss and
yeah,
pressures and a lot of things like that. So, the state of California, we have standing orders. The state of Washington, so our paramedics work in Spokane County, work under the standing orders. So they don't have to call and get permission from a hospital to do certain types of procedures and whatever.
Okay.
Where in California, where you used to see them call in on the little phone, and I think that's still the case in California, is that they don't have standing orders. They literally, the paramedics takes their direction from the hospital. And we actually in Washington, in Spokane County, our paramedics have a set of orders already, and so they know how to run a call and what medications to provide and whatever. I mean, we'll call medical control when you're doing certain types of calls where there's extended CPR or something like that. Once we start CPR, we don't stop it unless you get a physician to do that. A lot of times that takes place when you transport them to the hospital. Other times they'll call the hospital, and that's that somebody doesn't have any DNR orders or anything like that.
So if you can't find somebody's DNR orders or what we call POLST form here, you'll have to call in to.
Yeah, and I mean,
you mentioned orders. Is that like a physician order?
Well, it's a standing orders for the county on. We actually work under the license. Our paramedics do. We have a paramedic coordinator, and we have an ER doctor, a doctor that's oversees. So technically, our medics are working under his license in our county. So there's a set of protocols that they know and they study and they have to go, and those protocols are updated and sometimes moved around a little bit. They have to learn the protocols and whatever. So different types of calls, which tells them how to run a certain type of call, of meds, what meds to push and whatever. Back in the old days, we would just start doing CPR and you start pounding on the chest. Now what we have was pit crew type of thing where there's usually up to 7 people when we're doing CPR. There's people in the chest and somebody's in charge and they're changing everything at 2 minutes. There's a lot of standing orders, things to change to provide a better level of service to the public.
To the public. Yeah, I was going to ask you about, because you've got a paramedic unit that shows up, usually a couple people in the paramedic unit. Then you've got an engine company that shows up, right? So you got 3 to 5 people there, usually on a medical call, on a standard medical call. So they each have their own duties. Is that what I'm hearing you say?
Yeah, I mean, today people always question, why do you take that big fire truck on a call? Well, we use the tiered system in Spokane County and the fire district where there's always so many ambulances around. And so usually the fire stations are the closest. So the closest fire unit will get dispatched. Sometimes those are our engine companies in Fire District 9 are all ALS, which means they have paramedic on them.
Okay.
So they'll respond so they can get there quicker. Then the ambulance comes from a different location. And depending on the type of call, if we have an echo call, they'll send another engine so we get that 7-person crew on.
And what's an echo call?
That would be a full arrest.
Full cardiac arrest.
Full cardiac arrest, yeah.
Yeah.
Where an alpha call would be maybe somebody just slipped and fell out of a chair. Bravo call could be just somebody that has a twisted an ankle or whatever.
Okay.
But sometimes an alpha call will turn into an echo call, or an echo call turns into an alpha call because somebody was sleeping or type of thing. So they're just varying types of degrees. But basically you'll see the closest engine company and ambulance. Now, something that our fire district is going to be the first one in Spokane County. We worked for a year on it. Tomorrow we launch July 1st. Actually, tonight at midnight, our crews are already in place. We are going to be the first fire department in Spokane County to do full transport.
So when you say full transport, what do
So we have
an ambulance
ambulances.
company?
Yeah. So
Okay.
AMR has been doing ambulance transports within Spokane County for years. When I first started in the fire service, there's a number of different ambulance companies. There was Spokane Ambulance, Spokane Valley Ambulance, and over the years they kind of got Mercy Ambulance. They got merged and they got bought out, and then there was Life Fleet, which was a big corporate company, and today AMR, American Medical Response, is all over the country, really. So we have we have what they call the ambulance service contract. The city of Spokane had their own, the rest of the county had one. In the last few years, those kind of broke apart. So then District 4 had their own with the AMR, Spokane Valley did, and the rest of the county was kind of left with another one. And those, although they always look kind of the same, like those based off of how many ALS ambulances, how many BLS ambulances you're going to have, and they had a certain amount of time to respond, and there was different zones, rural, metro zones that had how long they can take to respond to a call or not. And what we were finding was they're a for-profit company, and we've seen their prices go up. And actually in Spokane County, AMR has some of the highest rates in Spokane, in the city of Spokane, of anywhere in the state of Washington.
Are you talking about payment rates?
Yeah, their rates, their transport rates are somewhere around $5,300 and then like $65 a mile. Those aren't the exact rates, but they're basically done with that. And then they're for profit. So there's basically ways they recover that cost. They get money through private insurance companies if you have it, Medicare, Medicaid, and things like that, and different programs. And if somebody doesn't have any of those, they might get billed directly. So
they're getting billed $5,300 plus 65 cents a mile.
$65 a mile.
$65 a mile.
Yeah, I mean,
I'm sorry.
Don't quote me on those exact numbers, but that's basically what it is. And that's gone up. We started looking at it and realized as the fire district, we wanted to change that up. So, if you look around the state of Washington and just across the border in Idaho, a lot of the fire departments are transporting.
Okay.
So we started working to get our transport license. It took us close to a year. We had a lot of help from the Washington State Council of Firefighters, the fire chiefs, the local politicians, both on the state and federal level, to push that through. And we finally, eventually, we got our license. We covered all the bases. So we bought 3 brand new ambulances, and we just bought 2 used ones.
And why are you doing this?
To cover costs. I mean, we're going to be able to do a transport for $2,200, what we set our rate at, and $42 a mile.
But why is the fire service, why is your district interested in doing that for the public?
Because it's going to save our taxpayers a lot of money. We actually, as a board, looked at that when our chief told us that. We told him we don't want the ambulance service to take money to fund our ambulance service. We don't want to use tax dollars money.
Yeah.
We want it to be self-sufficient. And it is going to be self-sufficient. We did some studies from the company that's going to do our billing for us. The company that does the billing does about 80% of all fire department billing for the state of Washington, Oregon, Idaho, and Montana.
Okay.
And they did some research on the number of calls we have in our fire district and the amount of money we would generate through private insurance, through Medicare and Medicaid. And what public entities have that private doesn't have is the GMT money, the ground emergency transport money. It's federal money that each state gets. And there's a formula and stuff. It's a really weird formula, but that actually helps compensate because the rates for Medicare and Medicaid payments are much less than what our standard costs were. But this GMT money comes in to actually
subsidize
that.
Yeah.
So what we're looking at is, and we're we're a bedroom community for the city of Spokane. We don't have a lot of lower income, but we have a lot of apartments and a lot of things like that too. But that we figured about 80% of our constituents will have some type of Medicare or Medicaid thing. And so they did a study, and the amount of calls we have in our transports, that just taking that money, we'd be able to pay for our ambulances, pay for the personnel. We just hired 21 new firefighters that graduated I think our graduation was on the 15th of June. They're all online today. As of today, they went on shift. And so today we have 4 ambulances sitting in our 6 staff stations.
Uh-huh.
And they'll now be there 24/7, and they will answer all calls within our jurisdiction.
Okay.
And,
Does
and
that
they,
reduce response time?
it'll do response time, and there's a continuity of care too, because instead of like our paramedic going out on an engine and starting care on a patient, and then another ambulance coming in and passing off the transport, you
Uh-huh.
know, we're actually going to.
What's the problem with that?
Well, there's that continuity of care, so you're passing off, and you kind of sometimes you get that guys are wanting to change up, or there's conflict or whatever. It's just once I've established patient care with you
Uh-huh.
and have that face-to-face communication with you, to be able to follow through all the way to the hospital. Now, that's not always going to be the case in our more rural areas where our engine companies are still going to be there ahead of our ambulances. But today, like if you take in the Meade Fairwood area, an ambulance and an engine, unless one's out, the engine and the ambulance are going to still go out together. So that paramedic on the ambulance will be the lead and will actually be the main care for that. There won't be any transport of care.
As a patient, is that better for me?
I think so. I mean, once that person has kind of come up with a treatment plan and is following through, again, it's a protocol thing. It's a full arrest. Everybody knows what's going on and what their piece of the pie is.
Yeah.
But other times, I work for different paramedics. Some have really good bedside manner and some don't necessarily.
Right.
But they get that rapport with the patient, and then they're right in the back of that ambulance and give them that support, and then they're transporting all the way to the hospital so that they're actually, from start to finish, they're handing off patient care.
So when they get to the hospital, they're then communicating with the ER staff or
Yeah,
the
they
ED
do. And we still have what the HERE system is. So en route to the hospital, they'll call the hospital and give them a basic report. But then when they bring them into the ER and transfer, there's that face-to-face communication that goes on with the ER nurse, maybe the physician or whoever that patient off to.
Yeah. Okay.
So
Well, anytime you're passing off information, there's always that opportunity for, unfortunately, miscommunication or something gets mistranslated or watered down or embellished or something, right? I did want to ask you a couple of questions. A lot of your medical calls are in the middle of the night, right?
Yeah, we are a bedroom community, so basically most of our calls are during the waking hours. Yeah, but you will get calls in the middle of the night.
Okay. And when you roll out on a call, and let's say you have somebody that's unconscious, what's kind of the first things you guys do? There's people standing around and they're like, this person's unconscious. We're not really sure what happened.
Well, not a nice thing is
information
we have
passing.
EMD with the dispatch center will actually start doing some type of questioning and stuff like that.
Questioning of whom?
The caller. Okay. And try to get a little bit of history and what's going on and whatever.
Yeah.
It kind of gives a little bit of a heads up. Not always the case, because sometimes, like I said, that alpha call turns into an echo, or that Charlie Delta call turns into an alpha call.
Yeah.
Somebody fell down, or maybe somebody's just dizzy, and then they're unconscious, they're not breathing, and you get there and all they're sitting up and talking to you when you get there. So that's one of the things about that. So they're giving you some information. But basically, it's like anything. It's like using your situational awareness when you walk into anything. And it's kind of what's the scenario, what's the scene, what's it look like. Our medics will come in and they'll start their basic protocols and, trying to determine what's going on with the patient. Is it an overdose? Is it stroke? There's just a lot of different things that they'll look at, and they'll start to treat them based on that. Most of the time, it's surprisingly how accurate our paramedics are in nailing those right down.
Doing the assessment. But you never know what you're rolling up on.
You never know what you're getting into.
If someone's unconscious, how do you get information about them personally, who to contact?
Well, basically, you're hoping there's somebody there, whether it's a facility or somebody. And basically, if somebody's living at home by themselves, we might get that phone call, and you're kind of at God's will to try to use the basic protocols, so draw blood and everything else, make sure they're not diabetic or what have you. But,
because you're not knowing what you're dealing with. So you do what? You draw blood?
Well, they'll draw a finger stick and see if somebody's diabetic. There's a lot of different protocols that they'll go through an unconscious patient. As long as they have a viable pulse rate and they're breathing and whatever, they may just be unconscious. So what's the cause of that? Are they diabetic? Have they have an overdose and stuff like that? So there's going to be some types of protocols that they go through, the medics do, to try to determine that. A lot of the times you might have, a husband or a wife or a kid or whatever, be able to give you some basic information on health information on the patient. The other nice thing today, though, is with all the, like My Chart, these different programs like that.
Can you access My Chart?
Well, not my chart per se. But I'm retired a couple of years, and the last 7 years I wasn't on the engine. We actually use a tablet and I'm going blank on the program,
Yeah.
but it accesses all the medical
Records.
and stuff like that.
Uh-huh.
So you can type one in. The nice thing is back in the day when we used to do everything by hand, they'd go back to the fire station and put it in a computer. That got downloaded, and that became national, excuse me, national, information. Today, that tablet, like I said, I'm going blank on the name of that.
That program that helps out
it's a
with that.
software, and it's actually tied in to the hospitals and everything else. So
Mhm.
it's a handoff. Our medics are actually, our captain actually, or the officer on the truck usually runs that clipboard. They'll start taking basic
information.
Uploading types of medications the patient has, history,
And were they uploading that information?
it's going into the
from?
computer, and then that all gets downloaded. And when it goes to the hospital, it's all downloaded right in the hospital. And that's actually how our billing is going to be working, because they're all integrated in together.
So because I've been on a number of scenes as an advocate for folks, and the fire department usually comes to me and starts asking me about medication lists to input. So they're asking family members, they're asking advocates, they're asking neighbors for that information. Is that accurate? It seems like what
yeah,
you
it's
just
just
said.
like that. Sometimes people that are a little more versed, you'll get some of the regulars,
Uh-huh.
and
The regulars,
the regulars that you go on more than
one call with them.
One
You know
call.
who they are?
Yeah, you get
Okay.
to know them personally. But you always have to go through the things, because maybe they had a change in medication, maybe they had something different.
Okay.
And every once in a while, you'll see the DNO or orders on the refrigerator, or
Yeah.
sometimes there'll be posts on the refrigerator, their list of medications
Yeah.
that hands it off. These medications are kind of a pain in right now, because it's like they're like a mile long, the name of something or whatever else.
They're hard to keep track of.
Yeah, they are.
Yeah.
And the thing is, though, is once that's been entered into the system, we'll be able to that system access that patient. So if I went on you on a call today,
Yeah.
and a week from now or a month from now or whatever, we go back, you can pull all that basic information up, and then you can kind of confirm it. That's
Yeah.
made the job a lot easier. And in the same way as that's how our insurance and everything else, because that's all tied into the hospitals, that goes out through the network insurance, Medicare, and everything.
So the information is key. Getting the information in is key. Getting the accurate information in is key. Making sure the information is always updated. Those are things that I'm taking away about, medications, and if you don't have that information, you're doing finger sticks to do blood draws to find out if they're diabetic and whether this is an insulin issue and those kind of things, so you can properly treat. Is that accurate?
Yeah. And
Okay.
I mean, even though you might have a list of medications, we're still going to go through them.
Yeah.
I mean, it's kind of like I deal with some health issues right now. And every time, I go to see my doctor, they ask you the same question,
Yeah.
and ask you, I mean, it's like you want to say, well, it's right there in front of you, but they ask you the same questions just to confirm, are you still on those medications or whatever?
Is the dosage the same?
And so sometimes those, there's just a set that they go through. So, well, you're there, the paramedic and the EMT, and so we're basically going to have 5 people. If one of our ladder companies goes, there'll basically be 4 and 2 for the ambulance. So,
Mhm.
so there's going to be 5 to 6 people coming on these calls to treat people, and the paramedic leads, and the EMT might be doing the blood pressures, and sometimes you'll have 2 paramedics on the scene. So one of them's kind of the lead paramedic, and the other one is maybe starting the IVs or
Yeah.
pushing the medications and things like that. So
Okay. So you're always checking with family or people that made the 911 call to get you there and alert you to the issue. You're just confirming information with those people about the person's maybe age, if they have a history of falls, if they have a COPD or they're a cardiac patient, and then the medication thing, confirming the medication's really vital and important, any recent hospitalizations, right? And then when you can get all that information and get it accurate, there's oftentimes a software system or an iPad.
well, health history is key to a lot of these types of calls.
Uh-huh.
I mean, things do change, but health history really kind of directs our medics in a direction on what might be going on with somebody.
Okay, like what kind of health history?
Well, cardiac history, cancer, diabetic,
Yeah,
COPD, a lot of different things like this.
some of the chronic diseases.
Yeah.
And
And
then,
when you walk into a scene and some of the patients, they're already on oxygen or different things.
Yeah.
Those are kind of key indicators of what some of the things that might be going on.
Uh-huh.
And then asking family, well, is that guy, well, he had lung cancer or he has methicilloma or different things like that. So
Yeah.
there's just a lot of different keys in there. I mean, it amazes me because I was never a paramedic and never wanted to be one, to be honest with you, but how dedicated these guys are and gals and through protocols and training and stuff like that. And it doesn't end the day they come out of school. I mean, it's ongoing. They have to have so many intubations, so many IV starts
Mm-hmm.
every year, and the doc oversees those. And our doc is an ER doctor that oversees our paramedic program. And actually,
Yeah.
the doctor we use sees a couple of departments within Spokane County, oversees their EMS programs. So there's monthly meetings for the paramedics to go to, and they'll take a look at calls. And he goes through it's amazed me, he goes through a lot of people's calls, and he'll look at certain ones that were, hey, this is a really good one. This is how this guy really nailed it. And this person over here, you're kind of off bases. This guy here, I mean, we have one guy that could be the poster child on how to write a report. And not only that, he's actually the poster child for an awesome paramedic. And the guy over here is kind of on the fringe, So that's where those medics coordinators can work on their skills too.
So constant training, information's key, education's key to doing all that. I'm fascinated by some of the scenarios you've brought up. I want to talk a little bit about auto accidents because I've been on the scene of a few auto accidents where people really aren't conscious and there's been extrication involved. What are the challenges for your paramedics, your firefighters when you're doing that? I mean, obviously there's trauma involved.
Well, it's trauma. There's a lot of hazards involved with that. I mean, stabilizing vehicles, both for fluids and rollovers and different types of things.
Yeah.
You can have a head on, and sometimes you might have a pull up on something and think there's nobody. Oh God, that's not survivable. And everybody's up walking around, and maybe one guy has a little bit of stiffness.
Yeah.
The next time you might see a fairly mundane looking car wreck that just the way the airbag or something happened, you'll lose that patient.
Mm-hmm.
But basically, it's like anything. When we do size ups, you do a size up just like on a structure fire. Car wrecks the same way. You pull up and you look at hazards, and the hazards might not be just what's in the car, but it might be traffic hazards because paramount safety is number one for our firefighters. So how they position a fire truck to block the scene, get out, start looking for patients. Sometimes the patients are out walking around. You try to get them out of traffic. And the next, somebody's totally unconscious and agonal respirations and things like that. So you get in there. And sometimes they come out easy. Sometimes you might have to do a full-on blown extrication.
Yeah.
In those cases, we bring a lot of extra equipment, not a lot more people to the scene. So then you'll actually have a medical group and an extrication group. So somebody's trying to get in there and work on the patient and stabilizing the patient where somebody else's might be just as simple as popping a door to get them out. You might have to do a dash roll. You might have to flap roofs. I mean, I've seen extrications take us as long as an hour. The other thing would just pop up and somebody's messing on this door because they got T-boned on the driver's side. We'll go open the passenger side and they slide right out. So it's just kind of what happens is guys over time get that experience to really be able to look at a scene and to figure out what's going on.
It must be challenging if you roll up on a scene and someone's unconscious or just kind of out of it. They're still semi-conscious and they might be allergic to latex or some type of medication. How do you know how to treat that?
Well, you don't. I mean, latex or whatever. It's life over limb. Yeah. It's life over limb. So they'll get there and they'll start looking at somebody. I mean, I remember one time we had when we get on a car wreck, one of the biggest things besides stabilizing the vehicle so that it's safe for the firefighters, it's to stabilize the patient. That might be ceasefire precautions, a lot of other stuff. And so again, that kind of comes with experience, and that's why the fire service, you're so many years a firefighter and then a lieutenant, a captain, or whatever. So you get that, but
So how many times when you're on a medical scene do you hear one or both of these phrases when you're asking for information from a family member or a Good Samaritan? You might be asking a medical question, whether it's, do you know what happened or whatever, but you hear the phrase, I don't know, or I'm not sure. Is that pretty common?
Well, it is. I mean, somebody doesn't live with that person all the time, or it's a neighbor that's come over, or a kid that doesn't really know that. And again, that that just comes back to that they're going to follow a basic set of protocols to try to treat that patient. And basically those protocols in our county may, in most cases, I think, they're right on, but nothing's ever 100%.
So those protocols were put into place by the county or by the state, first of all, just
basically our county protocols.
Okay.
The doctors come down from the ER.
Yeah.
And, so basically it's kind of like Johnny and Roy, they're calling in to ask the doctors, this is what we have. And the doctors kind of calling the shots. Basically, the protocols that are out there give our paramedics the ability to do certain things without having to call a doctor.
Yeah.
Basically what they see in front of them and try to size up and treat. It's just like going on a house fire, what type of house fire you have and how you're going to approach that house fire and, what type of lines you're going to pull and,
So correct me if I'm wrong, but it sounds like these protocols were put in place because people recognize that things could be better, or these are solution-driven protocols to aid in whether it's a fire and how to approach that safely from a firefighter standpoint to protecting property, or whether it's a medical call where you're really trying to give the best treatment the best way possible. You've recognized it over time, because when your dad started in 1966, is that what you said?
And the fire department didn't even go on any calls back then either.
Yeah.
They were just strictly doing fire. Johnny and Roy really brought the paramedic service or the EMS service into the fire service. And over years, as new building codes and things like that, our call volumes are exploded. I mean, and how many calls were going on compared to where we were 5, 10, 15, 30, 40 years ago. And a lot of that's just due to our population's growth, and there's a lot more of everything, car wrecks, fires.
Okay.
And so, those kind of trauma calls are how you go about dealing with those calls. I think with the elderly, you're really looking at it on different medical types of issues. So, a lot of those kind of come down to compassion. I worked with one paramedic. He's now a chief of a little fire district out in the central part of the state. He was one of the most compassionate. He had a bedside manner. And not only that, I would have had him work on any one of my family members. He was an excellent paramedic. But, he came in and he looked at what was going on and was able to very quickly size up and create a rapport with the patient. And if the patient wasn't able to respond to him because, for one reason or another, that they were unconscious or maybe their stroke.
Yeah.
And stroke patients, it's frustrating for them. So, you try not to make that frustration level go anything. And we know for stroke patients, we want to get them in the hospital as quickly as we possibly can. So then the bigger questions is, we'll start IVs and give them full flow O2 and stuff like that. But, thrombolytics is what they really need. And you got to do that in that first shower. So the big question is, well, when was this onset? Whatever. So, and, those kind of patients get quickly try to be loaded and transported.
Gone. Yeah.
The nice thing about that for our jurisdiction is now our ambulances are usually going to be
right there.
Yeah. I mean, there's times when we're in North Spokane County and you might have an ambulance that periodically a private ambulance might be a little closer to the call. Often that isn't the case. And, they could be coming from Sacred Heart or whatever. So our ambulances we feel are going to meet within the standard in the times for rural and metro and urban areas for, response times for getting them on the scene. So,
yeah. So when you bring up stroke patient, that's a complicated patient, right? And it's very time sensitive.
yeah.
Are there other things that they might be suffering from, other illnesses that can?
Well, sure they can. I mean, it's,
That
what brought
complicate it?
What brought on the stroke? I mean,
Yeah.
did they have a head injury, or the stroke could be actually not really a stroke, could be a bleed or something, which is stroke basically are.
But they could have a history of bleeding.
They could have history. They could have high blood pressure. There's a lot of different things. Yeah. So health history is really important. And actually some people will have those, orders in there. Once you've gone on a patient 1 or 2 or 3 times, some of that stuff just starts adding up. So they walk in, they can push a button and all that stuff loaded down in front of them. They just have to confirm it and helps them. So
it's that getting that health history because you're there 1 or 2 or 3 times. It's really important, and it's critical to the care of that patient. Correct?
Yeah. And sometimes somebody's really good about the spouse. Usually a lot of times it's the women with the man. They know exactly what dad's taking. Dad might be, well, she takes stuff and what's in here. So then you have to go dig it all out of the, but in most cases, everybody knows their spouse or whatever that they're medication says, here's their box, and here's my box. And
So you're having to dig through the boxes, or the spouse
yeah,
has?
usually they're kind of divided up, or they're in a medicine cabinet or whatever else.
Yeah.
A lot of times over the years, I mean, I would, okay, nobody was there. I don't know, well, the pills are in there. The daughter that lives across town or just visiting from out of state,
Yeah.
you'll go in and start digging through, and you write down all the medications. And people don't tend to throw a lot of medications away. It's just something they might have, so
Might be old and never taken it again.
yeah, they worked one time for them and didn't. But the bottom line is, I mean, health history and having that all written down and whatever. And then you'll have the really organized people. You walk in, they walk to the door, and here's
Is that better?
Yeah, here's your medication.
Why is that
stuff.
better?
Because there's not the question of, and that's just a matter of confirming.
Yeah.
All of a sudden you have that list, and you have maybe her health history or his health history and things like that.
Does that mean I'm going to get better care faster because
well, it's be
it's
able
less guessing?
Well, it's like anything. Is it a sprain or is it broken?
Yeah.
And I mean, and we're gonna treat everything like it's broken in the field.
Yeah.
But the bottom line is somebody that's, when you walk in and you're dealing with that patient in the middle of the night or in the middle of the afternoon, any information that's already pertinent and they already know, it's huge. A lot of times you go on that totally healthy person, I mean, it's scary, but every once in a while, you walk in on a kid that they're perfectly healthy, and all of a sudden there they are.
Yeah.
Cardiac arrest, or they had something or a genetic problem that nobody knew about. Those are the scary ones. Yeah. But a lot of other times we go in on something, and usually they don't call themselves, generally speaking, when they're dying or unconscious, right?
Right.
I mean, it can happen. It's rare. Somebody else is there, whether that be a caretaker or a family member. And usually they'll tell you, well, they have DNR orders, or we have hospice or whatever else. A lot of times the hospice care, I know my mom was at home when she passed away last summer, and we didn't have the fire department come out because she had hospice and DNR
You just had the
orders.
hospice nurse come out.
Yeah, and the hospice nurse had just been there earlier.
Mm-hmm.
So when we all were there, and when she passed away, we made the phone call, and Holy Cross came out. But it's those other cases where there is not that, and we get there, and we might actually start care, and then somebody produces they have DNR orders. Well, we need to see them. I mean, you don't want to take that chance of not resuscitating somebody that wants to be resuscitated, and just because they don't want to deal with them anymore or whatever.
Yeah. What do you do when somebody's not at home and the DNR orders aren't right there?
You start treatment until
What if they don't want treatment?
Well, I mean, the bottom line is, if they're conscious enough to tell you, they have the right to refuse that.
I'm assuming they're not conscious.
Well, we're going to they're going to follow those protocols and treat that patient until those no orders are pulled.
Even
up.
if the patient's lived a long aged life.
Yeah, I mean, most time, yeah. I mean, some pretty old people, but basically,
because that's what the law calls for, right?
Calls for, yeah.
And what happens when you do chest compressions on an older patient?
Well, you're going to hear a lot of cracking, and so that's just part of it. I mean, you're going to hear that even you're going to break sternums all the time when you're doing CPR on even a younger patient or whatever else. So, and those. Some of that goes along, I don't want to say call over the territory, but that's part of the treatment that's going to happen with them, and they're going to start IVs, or they might have to do an interosseous type of IV because their blood pressure is so low, and so they're going right into the bone or whatever. And again, it's all protocols based on how they're going to treat a patient. And I mean, granted, there's some leeway, you might say, in somebody that is like 102 years old versus somebody that's 68.
Yeah.
But basically, usually, somebody in the elderly like that are usually pretty, in most cases, have those DNR orders. And in most cases, they're not living alone. They're in some type of care facility, or, somebody's living there, a caretaker at home with them. It's not always, but, there's, generally speaking, there's somebody there. And generally speaking, when you go on those calls, they haven't called themselves. I mean, somebody else has made the phone call that you can usually try to get something out of or whatever. So, but having things written down and whatever is very important, whether you have some type of form or whatever else. So,
so that you can hand it to the firefighters and that
my mom had the green DNR orders hanging on her refrigerator.
Yeah.
And she chose that earlier on in her, mom was 98 when she passed away. And
Yeah.
she probably had that up there from the time she was in her early 90s.
Mm-hmm.
She was pretty spry, and, so in her 80s, she wanted to be, she wasn't ready to go. So, if she had a heart attack, we would have run.
You would have
Yeah.
done chest compressions.
Yeah, we would have.
That's what
We
run
would have
it
treated
means.
her and
Yeah.
what have you. But, and then you have comfort measures and things like that too.
Uh-huh.
Sometimes it's like, well, they don't want to have chest compressions, whatever, but we might be able to give them some medications and stuff like that they carry for comfort. And then they may and may not want to be transported. And
Yeah.
so those are all decisions that come from the family or the patient. But when there's nobody there that representing the patient, we have to, we then become the advocate for the patient.
So-
and the county protocols tells us what we have to do with
So
that
the
patient.
government's making the decision, and you're the
If
arm
you
of the
wanna
government.
I don't like when you say the government, but the bottom
Well,
line
that is.
that's what it
You're
is.
the representative of the government, right?
We're representing for the
So
EMS,
does EMS train to look for people's ID and their wallets or whatever, so they know?
Sure we do. You'll start getting there. I mean, we don't stop and look at a patient and like, well, go look for the stuff to already do that. That's where the medic will go right to start treating the patient and start treating them based off of the protocols, what they have in front of them.
Okay.
And start the process. Somebody else will start looking around if they're not there. Is there a lot of times there's a purse or a wallet and things like that.
Yeah.
But even a purse and a wallet, all that really, in a lot of cases, just gives you their basic ID. It doesn't tell you that. There's usually, most people don't carry a DNR order around with them.
Uh-huh.
In most of those cases, it's hanging on the refrigerator at home.
Yeah.
And that doesn't mean they don't, collapse when they're out over having Thanksgiving dinner over at the daughter's
Clap
house.
somewhere else in the DNR.
Yeah. And in those cases, the family, you can see that they have health issues or they're elderly and they don't have these DNR orders. And so they'll start working it and they'll they can call the hospital and say, hey, and give them the information. The doctor will say, yeah, you can stop that. And, we've done that too before. And
I have a question for you before you go too far. Do you get a doctor on pretty quickly if you're calling from the fire service, or you get put on hold? Like,
well, I mean, we have direct lines right into the ER.
uh-huh.
So we're not like calling like where I just
Okay.
came from to pick up my medication.
Yeah.
That you're on hold for half an hour. No.
Yeah.
When you call an ER, you get a pretty quick response. And but you're not just calling through the switchboard and for English 1 or whatever type of thing. It's a direct line right into the nurse's station.
Yeah.
And that nurse's station, there's usually somebody, always a nurse or somebody, person. When I say manning, a man or woman or nurse at that station. So when we call in on the HEAR system to give them, hey, we're bringing a patient in and whatever else, and give them the basic information, they can either use the HEAR system or they can make a phone call. And our medics all have like the clipboard right there. It gives you the name of whatever.
But a doctor has to give an order. The nurse cannot give the order, correct?
Yeah, those you're going to talk to a doctor when you're working on a patient like that. The doctor will get on and he'll say, no, I want you to continue that. Or no, you can go ahead and you can discontinue CPR.
What would make the doctor want to continue or discontinue? What information do they need?
Basically information that they're giving them. I mean, we have a 89 or 90-year-old, 95-year-old male patient, and we have no DNR orders on the family and so on and so forth, and give them basic information and say, okay, because today when we call ROS, when you get some ROS is when they're breathing and whatever before we transport. So they'll go through a whole series of things before they transport. If they get ROS where they have some spontaneous circulation and breathing and stuff like that, then they hold them. I think I can't remember. It's like 10 minutes or something before they'll actually try to transport. Before, man, you were just go, 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 go. So now they're realizing out in the field to try to stabilize that person. Yeah, and even like in CPR back in the old days, everybody thought it was lock lips and stuff, breathe for a person, and the most thing is circulation. So doing chest compressions is more important than the breathing part of it. So those types of things too. So when you call protocols and they call in the doctor and try to run it up, you're not going to see that on a younger person.
Right.
Or maybe it's a trauma or person or whatever like that, and you're just not getting any kind of response or whatever. And they've gone through 3 or 4 series of medications and whatever else, and the doctors say, okay, yeah, under the circumstances, you can
stop treatment.
Start treatment. A lot of times that kind of deals mostly with trauma or different
Yeah.
things like that too. But
It sounds like things are still evolving. They're getting better. You're understanding patient care more, and you're putting in place protocols to address those things, right? What I'm hearing a lot of is information is key. It doesn't matter where you're living or how you're living, and there's different scenarios all over the place. You might be at home, you might not be at home, and so the fire service is addressing all that and coming up with systems to help solve that.
yeah,
But it starts with the family and how good the information is that you're getting from the family. Is that accurate?
yeah, that's pretty accurate. And I mean, a lot of times, some people that are really on top of it will pull something right out of their purse and here's what I'm on and here's my health history. And boy, that's a big plus. Or,
That's a win for the fire service?
yeah. And the daughter might be next to him or that knows the mom's health history better than she does,
Yeah.
and those are all huge. But
You keep saying huge. What do you mean by huge?
having an idea, being able to understand what might be going on with that patient may not be, but health history kind of is a key indicator of what might be the underlying issue with somebody having difficult breathing or
Yeah.
having a cardiac issue.
Yeah.
And then a lot of times it's this perfectly healthy person out on the golf course and all of a sudden they flop over.
Yeah.
And the other people in the golf and they had no clue they had any kind of medical issue.
Yeah, it's interesting. You see all these athletes that are runners or whatever, and they die suddenly, and you just
What happened?
what happened?
Yeah.
So I guess there is no you don't have to be elderly to have a medical event. You can be at any age and have a medical event. You mentioned young people earlier.
Yeah.
That was tragic, but you've rolled up on some young people who have not made it. Right.
Yeah, and I mean, basically, as you get older in age, there's a lot more medical issues.
You have chronic disease
that
processes.
problems.
Yeah.
But you do hear from time to time, or our crews go on a call with somebody that just had a medical issue as a young person. The family may or may not have known about that.
Yeah.
And so I don't want to say history is everything, but health history is very, very important. And you know that because anytime you go to the doctor, they always ask you the same questions.
Same questions. Well, Commissioner Anderson, I want to thank you for joining us today. It's been very enlightening. We've addressed a lot of the questions just from where your dad started as a volunteer firefighter and then where you started in the 80s as a volunteer and then became a full-time firefighter. You started out in dispatch initially, right?
Yep.
Okay, and then you were on an engine company, and then you were promoted to lieutenant and captain, operation chief, and now retired operation chief and fire commissioner. So one, thank you for your service and dedication to that. But two, I think it's just really enlightening. I know we could talk all day about these things, but my takeaways from this conversation are, again, preparation. We preach preparation here. So information is key. You guys, or the fire service, is always looking for a better way and solutions to give treatment in medical emergencies, and families can be a big part of that in the sense of their preparedness to communicate with the fire service and just pre-planned. Would you agree with those statements?
Yeah, I mean, just like a fire, I mean, pre-planning, if we do a pre-plan on a building, it gives our guys just a much better avenue if the building's on fire on how we're going to deal with it.
Yeah.
So pre-planning a medical event by having the proper paperwork and the proper, things in place is just huge for our people when they come in to quickly assess and be able to treat somebody.
Okay. Well, good. Again, this has been The Voice of Aging. I'm your host, Brynne Malone with Aging Solutions, and I just want to thank Greg Anderson, Fire Commissioner here in Spokane County, for his time today. We wish you all the best, and join us again for our next edition of The Voice of Aging. Thanks for listening to The Voice of Aging. Like, share, and explore our services at agingsolutionsnw.com. And connect with us on social for more support.